relatively resistant epilepsy, and those patients ideally should be managed by specialist, because we need to rule out why it is happening and is there any other option. There is no timeline that for how many days we should wait. What is drug responsiveness? That is a very opposite of refractoriness. So what they say that if somebody is seizure free for 1 year or 3 times of seizure interval. So if somebody is getting every month one seizure, so 3 times becomes 3 months, but minimum is 1 year. So if somebody is getting one seizure per year, to say that this patient is relatively controlled, we should wait for at least 3 years. So that's how we can say about the drug response. So 3 times of the seizure frequency or minimum 1 year. So in terms of drug resistance, we can say only at a given particular point of time. Suppose today that this patient is not responding to 2 medication and you give third medicine and patient become seizure free. So that patient become practically drug responsive for next whatever 1 year, 2 year, or maybe even lifelong. So drug resistance is for that particular time of event. So if we see overall studies, the most common studies, epidemiological studies by this Martin Brody. He is a famous epileptologist in terms of studying long-term outcome in epilepsy. And the outcome wise they have mentioned that roughly 2/3 of the patient have good response. Out of them, half will have immediate response. You give any medicine, 1/3 of the patient will have excellent response. Another 1/3 will have response by either by adjusting dose or by giving another medicine. But 1/3 patient will definitely have an issue, and out of those patients, about 1/3 can have surgery and can be cured by surgery. So this is the distribution we have already discussed. The previous study was from Martin Brody, and this study is from India, almost same type of distribution. So when do we can say that this patient is likely to be drug resistant? So again, the study by Brody, it says that once you have tried more than 2 drugs, the chances of third drug failures are very, very high. So roughly more than 90%. So, but there are certain studies which have mentioned other way around, that even in patients who are not responding, if you try an unused drug, some percentage, almost 10 to 15% of the patient becomes seizure free. So even then you can say almost 80% of the patient, the chance of seizure freedom are less. So it's not an all or none phenomena. There is nothing like a yes or no. In some patient getting seizure 20 per month, and with the addition of medicine he becomes 1 per month. Though it is a good response, but for the family they may not be very happy. They still want them to be seizure free. So in these terms, even 1 seizure per year somebody is getting, for them it is drug resistance. Because as you see these juvenile myoclonic epilepsy patients, they just get seizure 1 per year otherwise also, even without medication. And if with medication they are still getting seizure even after 1 or 2 years, they will still feel that they are not free, they are not normal, kind of a bit of feeling that they are not normal, though they are normal otherwise. So once resistance is there, does not mean that it will always be resistant. There are certain mechanisms mentioned. I won't go into theoretical details. Issues with neurochemical changes. The refractory epilepsy can lead to SUDAP. SUDAP is sudden unexpected death in epilepsy, and it is there. It's not that we don't see it. Probably we don't ask in detail. At least I have an experience of 3 SUDAP in my last 10 years of career in Medanta. None expected that kind of death, but sudden death, and when we kind of asked them in detail, the patient was found dead at bed. Nobody has witnessed seizure. Prone position. So that is the commonest thing. So during sleep prone position, they are more likely to have seizures happening during sleep. The chances are 1 in 1 lakh, but it can happen. So if seizures are not well controlled, there are certain questions we should know. Is epilepsy diagnosis correct? Is classification correct? Are we giving the correct drug? Are we using correct dose? Is the compliance good? Then are we missing some MRI lesions? Is there any other trigger? So in terms of newly diagnosed epilepsy, you try 1 drug, 2 drugs. If it is refractory, we should ideally directly go for at least MRI and video EEG to try to diagnose what type of epilepsy we are dealing with. Not all patients with drug-resistant epilepsy are epilepsy surgery candidate. This was the study done where they mentioned that almost 1/4 of the patient are surgical candidates. Among these refractory epilepsy, roughly 20 to 30% are because of non-epileptic events. They don't have epilepsy, or they have epilepsy plus non-epileptic events. So we should definitely rule out these non-epileptic events. And to do this, video is the gold standard. We admit the patient, we continue video easy for a long time, 1 day, 2 days, 3 days, let the seizure happen. And then we record video and see the EEG and then make a final diagnosis. This combination, as I mentioned, combination of true and non-epileptic events is very, very dangerous combination. These patients may not respond to medications. They will need a good kind of counseling, good kind of psychotherapy, plus anti-seizure medications. And we need to have something like each event should be recorded by the family so that we can at least know what type of seizure the patient is having now. Is it true seizures or non-epileptic events? So whenever a patient is not responding when you are giving medications, first is history, evaluate, understand the semiology, review the medication patient is taking, ask for the compliance. Second step, again review the history, go back to the previous records. If it is clear that patient is having epilepsy, patient has not responded to medication, you can try 2 medicines, 3 medicines. At times you try 4th, 5th medicine also. But parallelly, you should evaluate from epilepsy surgery point of view. So what is pre-surgical workup and why is it required in patient with epilepsy? Why can't we directly operate a patient with epilepsy who is not responding to medication? Suppose somebody is having clear-cut mesial temporal sclerosis and patient is having epilepsy and not responding. Why can't we directly operate? The reason is a lesion present does not mean that is causing epilepsy. It's like proving that the person has done a murder, so we should have the proof. Just presence of somebody at the time of murder does not mean that he is the culprit. Similarly, if MRI showing some lesion and there is an epilepsy, it does not mean that the lesion is responsible for epilepsy. Because brain surgery is irreversible. If you remove hippocampal or MTS or anything, you can't reverse it. So before doing surgery, we need to have pre-surgical workup. So what does that workup basically means? That we want to know the seizure origin. We want to know from which part of the brain seizures are originating. So there are certain investigations, certain zones, epileptogenic lesional zone, which is visible in MRI. MRI may show this MTS. Then we may have some seizures which video EEG will show that seizures are starting from this area. Then spikes may come from any part of this part of the brain. So this is known as irritative zone, and that's what we want to remove. So this is epileptogenic zone. So how to pinpoint this epileptogenic zone and why can't we have a single investigation? Because the zone may be different, lesion may be somewhere else. There are epilepsies which have clear normal MRI. There are epilepsies like juvenile myoclonic epilepsy with incidental neurocystic sarcosis, incidental other lesions. The patient have epilepsy unrelated to that particular lesion. So when we do pre-surgical workup, these are some of the investigations we plan to do. Again, the first and most important is history, MRI, video EEG, psychological assessment. This much is the basic workup before considering epilepsy surgery. Then we do have other investigation like PET, SPECT, fMRI, invasive monitoring. So objective is to find the type of epilepsy syndrome, to know the area responsible, and then correlate clinically, electrically and radiologically. If clear-cut history-wise it is temporal lobe epilepsy, MRI clearly showing MTS, video EEG clearly showing that the lesion is coming from temporal, then we can clearly operate. So at the end of the pre-surgical workup, basically we want to know whether we can operate or not, what are the benefits, what are the risks. So we do start with history, do again all the detailed evaluation as we discussed, analysis of each and every part of semiology, aura, how the seizure happened. Home videos are also very, very useful. Then any neurocutaneous markers, any deficits, that also helps in making a surgical planning also. MRI, as I discussed in the first talk, we should have high standard of high resolution MRIs. Coming to video EEG, video EEG is a very important part of refractory epilepsy. We need to discuss why we are doing video EEG. We need to tell them that if you have a lesion and your epilepsy is coming from that lesion by video EEG, then we can consider surgery. So these points needs to be discussed before doing a video EEG. So we basically record seizures. We basically try to record at least 2 seizures, and then analyze each and every part of video EEG. So I'll just show 2-3 videos. So this particular patient came to us with his father is a urologist in West Bengal. The son, 12-year-old son, used to have some events every night. So they were not aware what it is happening. So the purpose of doing video EEG was to diagnose these events. He used to have some coughing, some choking, not able to breathe. So they evaluated from respiratory point of view, ENT point of view. Nothing could be found in the throat, nothing could be found from chest point of view. So this was classical frontal lobe epilepsy. Patient was very restless during sleep and had probably some throat sensation because of going into insula, and that's why he had cough and other things. So after starting carbamazepine, patient had excellent response, totally seizure free. So that's how EEG helps with the video. Once we have seizure semiology, once we have EEG during seizure, we can almost 95% cases we can tell which part of the brain is producing epilepsy. Then psychological assessment is equally important because we need to know whether patient is psychologically stable or not before surgery. How is the IQ? Is there any verbal memory deficit or non-verbal memory deficit? Some problem with display. Okay. So then when we consider for surgery, we make sure that we don't harm the patient. There should not be any worsening of memory. There should not be anything. So once we have done this MRI, video, EEG and clinical assessment, then we consider the patient for surgery. PET scan is required in selected cases, only in where there is a doubt, where there is a mismatch between MRI and video EEG. In this particular patient, you can see this beautiful hypometabolism seen in the left medial temporal structure. SPECT is again done in selected cases, and it's very difficult to do because you need to give the dye within 10 seconds, 20 seconds of seizure onset. So we have done couple of SPECT in Medanta. Other investigations like MEG, EEG, fMRI, these are newer investigations. MEG at present is available only in Manesar, this NBRI, National Brain Research Institute, and NIMHANS. Only 2 centers in India are doing MEG. Then certain other high density EEGs, instead of putting electrodes 18 or 19, you put 256 electrodes over the scalp and then record the EEG. Invasive monitoring basically means putting electrode inside the brain, and stereo EEG is nowadays being done in patient where MRI is normal, or we are not able to pinpoint the lesion by MRI and EEG. At the end of workup, we need to discuss each and every case whether we can operate or not. So among the surgeries, we can have these gangliogliomas, DNETs, cortical dysplasias, AVMs, cavernomas, and then we decide about type of surgeries depending upon lesionectomy. ATL and AH is the commonest type of surgery, anterior temporal lobectomy and amygdalo-hippocampectomy. Then we can have functional surgery, hemispherotomies, subpile resections, corpus callosotomies, VNS and DBS. These are some of the surgeries done. Commonest surgery is medial temporal lobe epilepsy. I'll just show one video. So this girl, she is a PhD student in university, and she had seizures for almost 10 years. She came to just without any referral. In fact, some of the people discouraged her for any surgery or anything. We discussed each and everything because she had that clear-cut temporal lobe epilepsy. She had MTS on MRI. She was taking 3-4 medicines. Family was totally against surgery. But she said, I'm independent, I will take my own decision. We did video EEG. So she had an aura, and the family was able to understand that it's going to happen. So during seizure, she just becomes silent. She doesn't speak. That is classical of temporal lobe epilepsy. Patient will have behavior arrest, will not be speaking in dominant hemisphere. Some chewing movement, if you can see, some lip chewing movements are there. This is known as automatism. So aura, arrest, automatism, amnesia of the event, absence of GTCS. These are classical features of temporal lobe epilepsy. She is not responding at all. And if you see the EEG, sorry. So this is the EEG. I'll just show. You can see this blue lines on the right side showing clear-cut evolution on the right temporal lobe. So this is mesial temporal lobe epilepsy. When the patient had seizure, the EEG was showing this. So this is video EEG. We need to correlate the ongoing video activity with the ongoing EEG. So you can just correlate by running both the things parallelly. You can see the EEG running and the video running. So clear-cut right MTS and right temporal lobe epilepsy. So she was operated. It's almost 6 years now, totally seizure-free, totally medicine-free. So almost 50% of the patients, especially temporal lobe epilepsy, we can stop anti-epileptic drugs. So last patient, this patient was from Rajasthan, so I thought I'll show you, from Sri Ganganagar. Very interesting boy. He had right hemiparesis. As usual, he was fond of music because his right brain was dominant. He had multiple daily seizures. Almost all were provoked by sudden sound. If any car is going, any horn is there, घर में है कोई बर्तन गिर गया तो सीजर आ जाएगा. So very pathetic state for family because बच्चे को आप कहाँ कहाँ अवॉइड करोगे आवाज़ से. They even started using plastic utensil की आवाज़ ना आए. This was clear cut left hemisphere which was gone. So I'll show you one video. In this video, just a minute, I think we'll have to close and open. Sorry. In one day we could get easily 10-20 episode because we just made a sudden sound and he will get a seizure. Say this. He is lying down silently. See this. See this right hand. I'll show you one or two more videos. The problem is he's lying down, it is okay. If it is standing, he will suddenly fall. Multiple falls. I think I had one video where he was standing probably. Let me see. Yeah. So in this video you can see he is standing, and what was happening, if you see carefully, the sister was just putting the side railing. Simple, very politely she was doing that sound, and he just about to fall. So this is known as startle epilepsy. So Dr. Aditya Gupta was with us at that time, and he beautifully did this functional hemispherotomy. So disconnection of the abnormal hemisphere from the normal hemisphere. Totally seizure free, studying, enjoying his music, enjoying other sounds, no problem, even using crackers during Diwali without any problem. So we are fortunate to have a full team of epilepsy. We have done more than 100 epilepsy surgeries, almost 80 to 90% outcome. Credit goes to definitely my training at Sri Chitra. I could learn and I could do it. So Dr. Radhakrishnan, I was fortunate to have got training under him. Thank you.
Very nice, very nicely covered. Dr. Anish is here. Yeah, Anish, another guy trained from same center.
We were
together.
We were there.
He is doing wonderful work here. So Anish, any comments, or can you please come? Meanwhile, if there are any questions or queries, because this is the last session, and I think my talk is only remaining, so I'll cover that in dinner. Because it's a far off place. I mean, all of you have to go to hotel. That's like 20-25 minutes. Then coming to that place. So overall 1 hour is transportation, Delhi time. But because Udaipur also has a lot of rush these days. So we'll be just winding up after this talk. So any questions or any comment, I mean, in any of the talks.
Thank you, sir, Atulab sir. And thank you, Dr. Atmaram, for nice talk. We are fortunate to have been trained in Sri Chitra. It's a dedicated epilepsy center. And our mentor and our teacher, Professor Radhakrishnan, he is probably known as father of Indian epileptology. And he has trained multiple students to the point that most of his students are carrying on good work in epilepsy. So Dr. Atmaram was my senior and very keen and an astute clinician. We learned a lot of things from our seniors as I learned from Dr. Atmaram. And we are even doing epilepsy surgeries in Udaipur and doing pre-surgical workup. And Dr. Aditya Gupta, whom you heard, he is training our surgeons for routine epilepsy surgeries. Okay, thank you.
Dr. Anish is running a very successful epilepsy surgery program. That is good work in Udaipur, definitely. Jayanti Mani. Yeah.
So we'll wind up. So tomorrow we have headache, Parkinson disease, movement disorder.
Sir, tomorrow
And,
your headache will also go down.
So fine. So we'll just, somebody has left his pen drive. So please collect it from registration desk. Welcome.